Hi, hello students. How are you? Hope all you are doing good. After a long time, I'm uploading a video. It's also under the cardiac system. It's mainly it is a basic of cardiac system. That is we are going to see about the ECG. Okay. So as we know already, if you are studying ECG, if you are looking with the ECG graphical representation, every time it is very new to us. So if we are having a every time we are having we are able to learn new thing from each ECG graphical representation. Okay, as per as our, we are taught that we are having a intuition like that the ECG will be cannot be rememberable for a long time. It will be we can easily able to forget everything what we are learned in a ECG. So I hope this class will you help you to improve your knowledge regarding the ECG and interpretation of the ECG. It is very basic. I am going to deal with a very basic thing which is there in a ECG and what is happening and what all the leads and what all the different types of the ECG electrical impulses and what is the different kind of a graphical representation. What is mean by that and all we are going to see one by one. Okay, hope you will understand this. Okay, so ECG means electrocardiography, which means the electrical impulses of the heart, which is represent as a graphical representation in a paper as a electrodes which is placed on the skin of a person in the chest wall, which is represent the electrical signal or electrical impulses of the heart. Understand? So we can mainly see about the conduction of the heart, and if there is any problem in that, we can able to identify with the electrical cardiography. Okay, so here we are having a updining of ECG. If we take updining of ECG, normally we are using in a bedside, we are using a 10 lead ECG. We are using a 6 leads in a chest wall, and then we are using a 4 leads in a as a limb leads. So that we are using. So in upcoming this class we will see about what all the leads and what is coming that, what is for that, like that. Okay, and then 3 sets of leads. We are having a 3 sets of leads, that is a standard limb lead, augmented unipolar leads, and then pericardial unipolar leads. So standard limb leads you can see like this, it will be 1, 2, 3. And then augmented unipolar lead. Augmented unipolar lead mainly AVR, AVL, AVF. And then pericardial unipolar lead is V1, V2, V3, V4, V5 and V6. Okay. So this is the 3 sets of leads that we are having. Okay. The next is a placement of the electrodes in the chest wall of a person. So when you come to the placement of the lead, the first lead is V1. So V1 we have to place in the fourth intercostal space in the left side, in the right side. Sorry, V1 we have to place in the fourth intercostal space in the right side. V2 we have to place in the fourth intercostal space of the left side. So V3 we have to place between the V2 and the V4. So when you come to this V1 and V2, it represent the anterior wall, and also V3 and V4 also representing the anterior wall. So when you come to the V4, we have to place in the fifth intercostal place and the mid clavicular line below the nipple. So for V4 we have to place it in the left side, fifth intercostal space, mid clavicular line below the nipple. Okay, and then V5 also we have to place it in the fifth intercostal space, left anterior or left axillary line, that we call it as apical area. And then V6 we have to place in the fifth intercostal space, Left mid axillary line, it is in a lateral side. So this is the placement of the chest slits. So where we have to placement, V1 is a fourth intercostal space of the right side, V2 is a fourth intercostal space of the left side, V3 is a, we have to place in between the V2 and V4, V4 is the left fifth intercostal mid clavicular below the nipple, and then V5 is a fifth intercostal space left anterior or left axillary line, mainly that it's at the apical area, and then V6 is a fifth intercostal space left mid axillary line to the lateral. So this is the placement of the chest slits. Okay, so we are knowing the placement and how we are calculating the heart rate with the help of this ECG. So how we have to calculate means, so we are having a two method. The first method is boxes method, and then the second method is RR interval method. Okay, the first box method is, so here we are having a 1,500 small boxes in a ECG paper. So count the number of boxes between the RR interval divided 1500 by that number. For example, so here you are having this RR interval. This RR interval, you will be having 25 intervals in a particular ECG strip means. So what is the rule? Here the rule is count the number of boxes between the RR interval. Number of boxes is 25 boxes. So interval is divided by or divide 1500 by the number. So 1500 divided by 25 equal to 60 beats per minute. Okay, understand? So likewise, we can calculate the heart rate. The next method is number of RR interval in a 6 seconds. So within the 6 seconds, how much the RR interval is here, and then the number of boxes into 10 in a 6 means a number of boxes in a 6 second, that into 10 equal to heart rate, which means first we have to check number of boxes of RR interval in a 6 seconds. So you can take the results 8 boxes. So that 8 boxes which is multiplied by a 10, the patient heart rate is 80 beats per minute. So this is the way we can calculate the heart rate with the help of the ECG strips. Two method. The first method is we are calculating with the help of the boxes. The second method is we are calculating with the help of the RR interval. So in that first method, so we are having 1,500 small boxes in a ECG strips. So we are calculating the boxes between the RR interval. So the RR interval, the boxes which means the 25. So 1500 which is divided by 25 equal to 60 beats per minute. So when it is next is the number of RR interval in a 6 seconds. So the number of boxes in a 6 seconds into 10. So the RR interval which is happening in 8 boxes in a 6 seconds. So that multiplied by a 10, your heart rate is 60 beats per minute. So this is the way we can calculate the heart rate of a person. Only small hint I can tell you, that is, if the boxes is increased, the heart rate is decreased. If the boxes is decreased, the heart rate is increased. So this is in this way we can able to identify. Boxes is increased, heart rate is decreased. So boxes is decreased, heart rate is increased. Okay, so this is the way we can able to easily remember the heart rate of a person. On to the interpretation or interpreting the ECG. So here you might have seen in a ECG graphical paper, you are having a lighter line and then a darker line. And so light and dark, horizontal and vertical line within a standard interval. So here with that lines, we can able to identify or we can able to calculate the time and rate with the help of the horizontal axis, and then voltage with the help of the vertical axis. Understand? So here in a graphical representation, we are having a light and dark lines in a standard duration or standard equal distance, and then in that the time and rate which is calculated by the horizontal axis, and then voltage which is calculated by the vertical axis. Okay, so if you see the ECG waveform which is moves in the top, that we call it as a that represent that a positive deflection. The ECG waveform which is moved to the top of the strip, that we call it as, that we indicate that is a positive positive deflection. And then the ECG waves which is moves at the bottom, so that we represent the negative deflection. Okay, so with that we are having a horizontal line and a vertical line which create a square boxes. So one small square which is has the there is a inner rate of 0.1 microvolt amplitude in the time of 0.1 second, the time for a small square. The time for a large square is 0.2 seconds. Okay, so this is the interpretation of the ECG. Under that we are having a, in the ECG strip we are having a light and dark, horizontal and vertical lines in a standard interval. So if you take as a horizontal and vertical, the horizontal axis which get you, with that we can able to identify the time and rate. In a vertical we can able to identify the voltage. So ECG waveform which is in the top, moves in the top, that we call it as a positive deflection. So the ECG waveform which is moves in the bottom, that we call it as a negative deflections. Understand? So the one small square box which is in the voltage of 0.1 microvoltage amplitude in a time of 0.4 second. In a large square which is in a voltage of 0.5 microvoltage and which is in the rate of 0.2 seconds. So this is the interpretation of the ECG. The next is, when you take a ECG which is composed of waveforms, segments and intervals. Waveforms, segments and intervals. When you come to the waveforms, we are having a P wave, QRS, T wave and U wave. And then when you come to the segments and intervals, we are having a PR interval, ST segment, QT interval, TP interval, RP interval and then RR interval. So like that, these kind of a segments and intervals we are having in a ECG. Okay. Next we move on to the ECG. So here, so this is the graphical representation of the ECG of a person. So in this we are having this part is called it as a P wave. So this is, we call it a, why it is happening? It is the atrial depolarization. So the electrical impulses which is get activated. So the muscles of the cells which is get electrical ions and which is get react towards that. So by that we call it as a atrial depolarization, which is happening in a 0.11 seconds. So the P wave which is indicate the electrical depolarization. The next is a Q wave, R wave, S wave, T wave and U wave. Next one is the QRS complex. This is, we call it as a QRS complex. The QRS complex which is the ventricle depolarization. So depolarization means there is electrical impulses to the particular cells of the particular area, which is according to the impulses which is react towards the impulses or electrical impulses, that we call it as a ventricular depolarization. So it is happening in a time rate of 0.12. So when it is happening, it is changes through the atrioventricular bundle of Kiss and Purkinje's fibers and the ventricles. So in that part it is happening. The next is a PR interval. PR interval is atrial repolarization. Repolarization means relaxation. Repolarization means relaxation, and again it is ready to attain other impulses. So here there is a time is there to the SA node or sinus node to be stimulated. there is a time. So until it will be waiting, that we call it as a PR interval. So it is taken place in a 0.12 and 0.30 seconds. Next is a T wave. T wave, which is represent the ventricular repolarization. Repolarization means which is get relaxed and it is waiting to attain another electrical impulses. The next is ST. ST means early ventricular repolarization. Early ventricular repolarization. Early it is waiting for a ventricular depolarization. And next is a QT. QT is, it is at the time for a ventricle contraction and the ventricle's relaxation. The time which is between the ventricle contractions and the ventricle relaxation, that we call it as a QT intervals. Understand? So this will be happening in a 0.3 seconds to 0.4 seconds. So when you come to the QT interval, if the person is having a low calcium level, which may leads to the prolonged QT interval, it will take time, the prolonged to contracts and prolong to relax of the ventricles, so that may leads to the cardiac arrest of a person. So when you come to the ECG, we are having a P wave, Q wave, R wave, S, T and U wave. The P wave, which is indicate the atrial depolarization, and QRS complex, which is indicate the ventricular depolarization, and PR interval, which is indicate the atrial repolarization, and the T wave, which is indicate the ventricle repolarization, and ST, which is indicate the early ventricular repolarization, and QT, which is indicate the time the time between the ventricle contractions and the ventricle relaxation. So when it is the low calcium level, which is prolonged the QT interval, so the person will be lead to the cardiac arrest. So this is the happening. This will be, we have to know in the ECG. So next we move on to the intervals as well as the segments of the ECG strips. We can see about the waves and intervals and segments now. Okay. So this is the waves of ECG, P, Q, R, S, T, U. So the P wave, it is a represent the atrial depolarization. So the impulses which is erased from the sinus node and it is sweep over the atria, that is representing the P wave. So and then QRS complex, this is the QRS complex. So this is the represent the ventricular depolarization. The ventricles which is attain the electrical impulses, by the time it will be has this QRS complex. So when you come to the QRS complex, we are having a Q wave, R wave and X wave. S wave. Understand? So we have already know there is the it is the waveform which is in the flows or which is lining on the top, that we call it as a positive deflection. It is which is towards the waves towards the bottom, that we call it as a negative depletion. So here we are having a QRS complex. So in that, the Q is the first negative deflection after the P wave, because you can see the Q wave, which is waveform will be towards the bottom, and then R wave is the towards the top. So it is a positive deflection, first positive deflection after the P wave. The next again is a S wave. So if you see the X wave, it is arises bottom. So the S wave, which is the first negative deflection after the R wave. First negative deflection after the R wave. This is, we call it as a QRS complex. This QRS complex, which is accompanied in a three small boxes. Okay, the next is if the waveform is less than 5 mm, we represent this is a small letter QRS. If it is more than 5 mm, we represent that QRS complex is a capital letter QRS complex. Understand? Okay. The next is a T wave, which is indicate the ventricular repolarization, and the U wave, which is indicate the Purkinje's fiber repolarization. So when you compare to the T wave and the U wave, T wave is a more prominent than the U wave. So this is all about the waves. So the first is a P wave, it is atrial depolarization. Here the impulses arises in the SA node and sweep over the atria. And then QRS complex, it is a ventricular depolarization. So here we are having a Q wave, R wave, S wave. Q wave is a first negative deflection after the P wave. R is a first positive deflection after the P wave, and then S is the first negative deflection after the R wave. And then the wave is which is less than 5 mm, which is we represent as in a small letter Q or S. The wave is more than 5 mm, we represent as a capital letter Q or S. Understand? And then the T wave, which is representing the ventricular repolarization, and then the U wave, which is representing the repolarization of the Purkinje's fiber. The next is the interval. We are having a PR interval, QT interval, TP interval, PP interval, RR interval. The first one is PR interval. So here you can see this is we call it as a PR interval. We call it as a PR interval. So here it is a beginning of a P wave and then beginning of the QRS complex, beginning of the P wave and the beginning of the QRS complex, that we call it as a PR interval. So here there is a which is represent the time which is needed for the sinus node stimulation, atrial depolarization, ventricle depolarization. Okay, so within that what and all it is happening? Sinus node need to be stimulated. The P wave which is representing the node which is get stimulated so that the atrial depolarization will be taken place. So that the sinus node stimulation, atrial depolarization and then ventricle depolarization. QRS complex which represent the ventricle depolarization. So this is what happening in a PR interval. The next is a QT interval. QT interval. So the QT interval is the beginning of the QRS complex and then end of the T wave. Beginning of the QRS complex and the end of the T wave. So here what and all will be happening? QRS complex is a ventricular depolarization. The T wave which is happening due to the ventricular repolarization. So here within this interval there is a depolarization of the ventricles as well as the repolarization of the ventricles which is taken place. Mainly this duration will be a 0.32 to 0.40 seconds and then the heart rate will be between the 65 to 90 beats per minute. So the QT interval which is taken place between the beginning of the QRS complex and end of the T wave. Understand? So here the time which is record for the ventricular depolarization and then ventricular repolarization. So the mainly the time between the 0.32 to 0.420 and then the heart rate will be 65 to 90 beats per minute. The next interval is TP interval. So TP interval. So here in this TP interval is there is a end of the T wave and then beginning of the next P wave. End of the T wave and then beginning of the next P wave. So next beat going to start. So in between there will be a isoelectrical state. Isoelectrical state means there is no electrical impulses between these the end of a T wave and the beginning of the P wave. So you can see there will be a flat line in between the TP interval, the flat line which will be represented in the graphics. Understand? So TP interval is there is end of a T wave and beginning of the next P wave, beginning of the next segment of P wave. So that it is state we call it as a isoelectrical period or isoelectrical state. In this there is no electrical impulses. It will be representing the flat line wave between the T and P. The next is a PP interval. So PP interval is beginning of the P and then beginning of the next P wave. So here which is helps to determine the atrial rhythm and rate. atrial rhythm and rate, which is determined by the PP interval. PP interval. Okay. The next is a RR interval. RR interval. So RR interval is RR interval. So RR interval is, it is the distance in between the two QRS complex, between the two QRS complex that we call it as a, or two RR interval, two RR wave that we call it as a RR interval. So which is helps to determine the ventricular rhythm and rate. It helps to determine the ventricular rhythm and rate. This is the intervals. So intervals, the first is the PR interval. So PR interval is the beginning of the P wave and beginning of the QRS complex. Here the time is needed for a sinus node stimulation, atrial depolarization and ventricle depolarization. The next is a QT interval. So QT interval is a beginning of the QRS complex and end of the T wave. So beginning of the QRS complex and end of the T wave. The time is required for a need for ventricular depolarization and ventricular repolarization, the time between the 0.35 seconds to 0.40 seconds. Here the heart rate will be a for now which means 65 to 90. And the next is a TP interval. TP interval. It is taken place in between the end of the T wave and then beginning of the arise of the next P wave. Beginning of the next P wave. So here it is, we call it as a isoelectrical period because there is no impulses in between the T and next P wave, so that you can see a flat line. And next a PP interval, beginning of the first P wave to the next P wave, that we call it as a PP interval. With the help of that, we can able to identify or determine the atrial rhythm and rate. The next is RR interval, between the two QRS complex or between the two R wave. We are determining the RR interval. This RR interval which help us to determine the ventricles rate and rhythm. Ventricles rate and rhythm. So this is the intervals which we can see in the ECG strips. The next is a segments. Next is a segments. Segment is, first is a PR segment and then ST segment and then TP segment. So PR segment. So this is the PR segment. Understand? So end of the P wave and the beginning of the QRS complex, that we call it as a PR segment. And then ST segment is end of the QRS complex and beginning of the T wave is called it as a ST segment. So in MI we are having a inversion ST or elevation STMI, inversion STMI, like that we are checking. Okay, so this is the main indicate for a myocardial infarction. So ST segment is a end of a QRS complex and beginning of the T wave. The next is a TP segment is end of a T wave and beginning of the P wave of a person. So this is, we call it as a waves, intervals and segments of the ECG strips. Okay. Next, we move on to the types of dysrhythmias. So this is not an exact class of dysrhythmias, cardiac dysrhythmias, but we are going to see about according to the ECG waveforms. Okay, so this is not exact cardiac dysrhythmias. For upcoming days, if it is possible, I will upload the classes of cardiac dysrhythmias. So this is only the based on the different types of waveforms, how we can do and how it is happening. Okay, how we can check the waveform like that. So when you come to the types of dysrhythmias, bradycardia, tachycardia, atrial flutter, atrial fibrillations, supraventricular tachycardia, premature ventricular contractions, ventricular fibrillations, heart blocks. Understand? So first one is sinus bradycardia. Sinus means there is a rhythm and the rate is a normal. So the rhythm of heart is a normal, that we call it as a sinus. Brady means below, the heart rate is below, that we call it as a sinus. The rhythm is a normal, the rate is abnormal, that we call it as a sinus. So sinus, anything bradycardia or tachycardia. Bradycardia means below, tachycardia means higher. So here sinus bradycardia means the heart rate is, the rhythm of the heart is normal, but the heart rate is below the 60 beats per minute, 60 beats per minute, that we call it as a sinus bradycardia. So here the one of the main major ECG variation here we can able to identify is here the RR wide, RR interval is wide, RR interval is wide. So already we have seen earlier of this class, the RR interval is high, the heart rate is decrease. RR interval is low, the heart rate is increase. So here the P wave and the PQRS complex and everything is same. But only the one variation here is there is a widen RR interval, widen RR interval. So here in which way and all it will be causes. Either we are doing a vagal maneuver or vagal stimulation or extra carotid massage in order to improve the bloods, and then sleep apnea, and then hypothyroidism, hypothermia, and then we are checking with the rectal thermometer. So keep it in your mind, those people are having a cardiac problem, do not check or do not prone to check the temperature in the rectal. Okay, it is very contraindicated with a person with the cardiac disorders because it suddenly lead to a there is a sinus bradycardia of a person. So when you come to the management, we have to find out the exact cause and then we have to treat the person, and also we have to administer the oxygen and then drugs like atropine, adrenaline, and then epinephrine. So why we are means that all the system, all the organ secretions also which is get decreased in case of a sinus bradycardia. Sinus bradycardia means there is a normal rhythm and the heart rate is decreased. Heart rate why is decreased? There is a widened RR interval we can see in the ECG strips. So as already we know, there is a increased RR interval, there will be a decreased heart rate, and the decreased RR interval there will be an increased heart rate. Understand? Okay. The next is a sinus tachycardia. Sinus tachycardia, the rhythm is normal but the heart rate is above 100 to 180 beats per minute, that we call it as a sinus cardia. So you can see the interval between the RR wave, that is a shorter. So there is a less interval and then more heart rate. So here how it is causes, the person may be having a hypothyroidism, hypothermia, those who are in a stress or in a pain or in exercise, those who are using the bronchodilators, example albuterol, and then those who are using the atropine. So those patients may be having a high in a heart rate. What is the management? We have to find out the exact reason or exact cause. According to the, we have to treat the person, and then we have to administer the beta blocker propranolol. Okay, this is about the sinus tachycardia. So sinus bradycardia, the rhythm is normal, the rate is low. Sinus tachycardia, the rhythm is normal, the rate is high. So here in a sinus bradycardia, the RR interval is widened. In a sinus tachycardia, the RR interval is a shortened. Next is another dysrhythmias. The first one is atrial flutter, atrial fibrillation, and then supraventricular tachycardia. So atrial flutter, from the atrial itself we came to know atrial, which is representing the which is represented by the P wave. Understand? So if it is committed, there is any problem in the atrium, so we can see the changes in the P wave. So atrial flutter is flutter which is occur in the atrium and create the impulses at the regular rate, and then it is identified by the P wave is indefined. The P wave is indefined. We cannot able to find out the P wave, and then the QRS complex is in a narrow. It is everything in the same size. Everything in a same size. Atrial flutter, the P wave which is unidentifiable. We cannot see the P wave. And then the QRS complex is a narrow, which is in a same way, that we call it as a regular rate. In the same way, same manner we can see. So here this way we otherwise call it as a sawtooth appearance, sawtooth appearance of a P wave, sawtooth appearance of the P wave which is there in a atrial flutter, atrial flutter. So here the heart rate will be a 240 to 340 beats per minute. So in which conditions and all it is occur? It is occur CAD and then hypertension and then mitral valve disorders, it will be occur. When you come to the management, we have to administer the beta blockers, calcium channel blockers, adenosine 6 milligram IV and then cardioversion, radio frequency ablations, RFA, radio frequency ablations. And then cardioversion is a plant electrical shock to a person, that we call it as a cardioversion. Understand? Okay. So atrial flutter, atrial which is indicate the P wave. Here atrial flutter which is occurs in the atrium and creates the impulses in a regular rate. So here in a P wave is unidentifiable. We cannot make out the P wave. You can see the ECG of the atrial flutter. So we cannot able to see the P wave which is in a regular interval. The QRS complex in a narrow and which is in a regular interval. It is like a sawtooth appearance of a P wave which is present in the atrial flutter. Next is a atrial fibrillation. This also atrial. So you can see there is a changes in the P wave. So here irregular rate means we can identify the waveform which is not in a regular way. Irregular rate, the heart rate will be a 3.50 350 to 600 beat per minute. So here no defined P wave and then the then the narrow QRS complex, it will be occurs in at any shape. You can see the shape of the wave. It will be occur at any shape. Okay, that we call it as a irregular rate. So due to a irregular rate, there is an indefined P wave, a narrow QRS complex, and it will be appear in at any shape, that we call it as a atrial fibrillation. This is the main difference between the atrial flutter and then atrial fibrillation. Atrial flutter, there will be a regular rhythm. You can see the ECG strip in the shape will be very same. There is no defined P wave and then QRS complex is very narrow. You can see there is a from the start till the end, the wave is in the same manner. When you come to the atrial fibrillation, there is an indefined P wave, but the rate is irregular. We cannot able to identify the shape of the wave in the same manner. Causes is there is any formation of clot due to a stroke or anything, or in some other conditions also. Management. Here we have to, first is anticoagulants and then we have to administer beta blockers, calcium channel blockers, digoxins and then electrical cardioversion, and then we have to administer the aminodaron to stabilize the unstable rhythm to the normal rhythm, because it is appear in a irregular rate, no unstable rate to the normal rate. So this is about the atrial fibrillation. The next is a supraventricular tachycardia. Here it is an abnormal faster rhythm which is originate from the atrioventricle or in the atrium. So it will be like this, understand? So here it is abnormal faster wave. So we cannot able to identify here the P wave or in the QRS complex. QRS complex we can identify, but it is a very fast rhythm, very fast in a manner. So the features will be, the person is affected with the SVT, the heart rate will be 150 to 270 beats per minute. The features will be shortness of breath, palpitation will be there, loss of consciousness will be there, chest pain will be there, tachycardia will be there, and then dizziness will be there. So when you come to the management, we have to administer the adenosine. Why we are administering? To stabilize the unstable rate and rhythm, and then vagal maneuver, beta blocker, cardioversion, radio frequency ablations, and then aminodaron. So these are the management of SVT. SVT, which is nothing but it is, we call it as a supraventricular tachycardia. So here there will be a So here there will be an abnormal fast rhythm and which is originate from the atrioventricle or in the atrium, and then it is having a heart rate is a 150 to 270. The features will be shortness of breath, palpitation, loss of consciousness, chest pain, tachycardia, and dizziness. Management is adenosine vagal maneuver, beta blocker, cardioversion, radiofrequency ablations, and then amiodarone. Next dysrhythmia is ventricular tachycardia, and then ventricular fibrillation and heart blocks. Understand? Okay, ventricular tachycardia, it is mainly based on the QRS complex. QRS complex which is representing the ventricular depolarization. So here this ventricular tachycardia, if we are not treated properly, that may leads to the cardiac arrest of a person. So when you come to that, there is abnormal QRS complex. The heart rate will be a 140 to 250 beats per minute. Here we are having two types of ventricular tachycardia, that is a monomorphic ventricular tachycardia, polymorphic ventricular tachycardia. Monomorphic ventricular tachycardia, polymorphic ventricular tachycardia. So monomorphic means there is abnormal QRS complex, but it is in a similar way. Abnormal QRS complex which is in a similar way, that we call it as a monomorphic ventricular tachycardia. And then polymorphic ventricular tachycardia means there is an abnormal QRS complex. It will be varying in a size. You can see a ECG. So here it is a monomorphic. You can see the QRS complex in a same shape. In a polymorphic, it is a varying in shape. You can see the QRS complex will be in a different shape. That we call it as a varying shape of polymorphic ventricular tachycardia. So here it will be like this. The ECG will be like this for ventricular tachycardia. So there will be a wide QRS complex, the P wave which is visible, but the PR interval which is not measurable. Understand? QRS complex is abnormal, P wave is visible, and then PR interval which is not measurable. We cannot able to measure the PR interval. Understand? Okay, here we can categorize into two patients when it comes under the ventricular tachycardia, stable patient and unstable patient. So when you come to the stable patient, here there is a pulse is present. The pulse rate is present for a patient of a stable VT. So here there is no signs and symptoms of decreased cardiac output. And then we have to administer the amiodarone, lidocaine, cardioversion or planned electrical conversion we can give for a person of a stable patient. When you come to the unstable patient, there is no pulse. There is no pulse. Pulseless VT. We call it as a pulseless VT. So this pulseless VT, we can see the signs and symptoms of decreased cardiac output. Decreased cardiac output. Management, defibrillations, and then ICDs. Defibrillations and ICDs. So this about the ventricular tachycardia. Ventricular tachycardia, it indicates that the abnormal QRS complex. Here there will be a widened QRS complex. P wave we can identify, but PR interval which is not measurable. So here we are having a two types, that is a monomorphic and then polymorphic VT. Monomorphic VT and polymorphic VT. So monomorphic VT, the QRS complex which is abnormal, but it is in the same shape. The polymorphic VT, the QRS complex is abnormal, but the shape is varying. So here we can categorize into a pulseless VT and pulse VT, or stable patient or unstable patient. Now comes under the stable patient, there is a pulse. There is no symptoms of the signs and symptoms of decreased cardiac output. So pulseless VT, here there is no pulse, but you can see the symptoms of decreased cardiac output. Okay. So next is the ventricular fibrillations. Ventricular fibrillations. Here there is impulses from the irritable foci. It is in a disorganized way. It is in a disorganized way. We cannot able to identify the ECG waveform. We cannot able to identify the ECG waveform, which will be like a like this. Like this will be present. Understand? So if we not determine, or if we cannot find out the person is in a ventricular fibrillation within 3 to 5 minutes, we have to find out and we have to give a treatment to a person, or otherwise we could lose the patient. good lost the patient. This is one of the fatal conditions of VF, ventricular fibrillation. So this ventricular fibrillations which happening due to a irritable foci. So here it is a fatal conditions, and then we need to determine and we need to treat within a 3 to 5 minutes, and then or otherwise it will be lead to a fatal. So here management, it has to be order. It needs to be order. We have to give a defibrillation, CPR and aminodaran. Defibrillation, CPR and aminodaran. That's all about the ventricular tachycardia and ventricular fibrillation. Next we move on to the heart block. So heart block, we are having a first degree AV block, second degree AV block and third degree AV block. We see by one. First degree AV block, there will be a delay in the conduction of the AV node. Delay in the conduction of the AV node. So there will be the PR interval will be a 0.20 seconds. Understand? And then second degree AV block is, so here there is one or more impulses which is fails to conduct the ventricles. The atrial impulses 1 or 2, it is fails to conduct the ventricle. So that what we can see, there will be a missing of the impulses, there will be a missing of the QRS complex. So you can see in the ECG, okay. This is, we call it as a second degree AV block. So first degree AV block, delay in a conduction of the AV node. Second degree AV block, there will be impulses from the atrial, it is fails to conduct the ventricles. So here there will be a missing of the 1 or 2 impulses and there will be a missing of the QRS complex. When you come to the second degree types, we are having a 2 types, that is a type 1 and type 2. Type 1 is Mobitz 1 Venkiba and type 2 is Mobitz 2 is Hay. Okay, so type 1, there is a problem with above the AV node. The problem with above the AV node, there will be a missing QRS and then progressive prolonged PR interval. And drop QRS complex. Understand? So this is the main difference between the type 1 and the type 2. Understand? In the type 1, problem is above the AV node. Here, progressive prolongation of PR interval. Progressive prolongation of, it will be continuing. The PR interval prolongation will be continue. And then there will be a drop in the QRS complex. The next is a type 2. Problem is below the AV node. There is a missing QRS complex. Here, constant PR interval and missing QRS complex. The type 1, progressive prolonged PR interval. Type 2, constant PR interval. Understand? This is the main difference between the type 1 and type 2 of second degree AV block. Third degree AV block, there is a impaired of produce of impulses by the SI node. It cannot able to reach the ventricles. Because there will be a complete block. Due to a complete block, the impulses from the SI node which cannot able to reach the ventricles of the heart, it cannot, the SI node, it is impaired to produce also. So when the ECG will be like this. Understand? ECG will be like this. So when you come to the here, there is no, in a ECG there is no relation between the P wave and the QRS complex. You can see, no, there is no relationship between the P wave and QRS complex. When you come to the management, if it is a first degree AV block, there is no management. Second degree AV block, we have to administer the bolus atropine or atropine therapy, and then we have to go with the placement of pacemaker. Under the heart block, we are having a first degree AV block, second degree AV block and third degree AV block. So with this, we are completing the ECG. Only we have see about the leads, placement of leads, rhythm, rate, and then what is the abnormal waveforms we can see in the ECG strips. Hope you understand this, and then if you have any doubts or anything, you can communicate in comments, and then hope you enjoy this class. Take care. Bye bye. See you in the next.